Thank you, Brito, for sharing that, and as well for the resident perspective. I think you know this is both exciting and daunting. These types of stories, for the rest of the audience in America who's not living this day to day. These are some of the very challenges we are addressing literally on a daily basis, and hearing these stories and working together as a team with the residents, with the specialists, with Dr. Brian to try to figure out how to sit with some of these challenges of integrating in the hospital, to establish the relationships needed, the trust needed to function as a department, and all of this is very much in flux because it hasn't been done before. There hasn't been a team leading resuscitation in quite this professional manner, and so you can imagine that it takes a lot of effort, just the amount of work I'm hearing that was put into that case, and yet frustrating at the same time. I just want to say thank you again for sharing, and for on a daily basis fighting that fight, trying to establish yourselves as new specialists in the area.
The challenges that Brito just described are not dissimilar to the challenges we faced back in the 1970s when emergency medicine was a new specialty in the US. We were regarded as the hippie doctors and the superannuated residents, and it takes time, and it takes communication, and it takes results to convince some of the more established specialties of our value. So I can give you that perspective as someone who's been involved in emergency medicine for over 40 years. We have a great deal of credibility in the US, but that did not come overnight. It takes time, and it takes a lot of communication.
Thank you, Patrick. Kevin, I know that
Hello.
prepared a couple of presentations. If you want case summaries.
Yes.
Hello.
Yeah.
Sorry. I have a problem with it. Yeah, I would like to finish my presentation. I don't know if it's the appropriate moment. Hello. Hello.
You should go for it, Dino. No?
Yes.
Yes, Dino, yes. Sorry, we're facing a big problem with net. Okay, can I continue?
Yes.
Okay. Yeah, my second part of my presentation, only I want to show you that, how Brito said, really we're facing a big problem with the ICU and the other departments because they don't have idea how is our, but we are doing our best and demonstrating how much we are important for the emergency department. About this question, about this problem with the other department, that's why I'm thinking to do a research project to show the hospital how much the emergency department is important for hospital, principal our hospital, because we are Maputo Central Hospital, the higher hospital of Mozambique, the level 4. It is the first hospital we can attend, we can give care of the patient of a more higher problem. Yeah, that's why I'm doing this. In this time, I'm reviewing the literature. I don't have the research question. I don't have the exact topic, but my objective is to measure our impact at Central Hospital. That's why I have many literature that I'm learning now. I'm reading it to elaborate my hypothesis, my alternative hypothesis. Maybe Dr. Kevin or Dr. Brian can help me how to formulate it and start my studies. Only I want to show you the review. Maybe all of you can help me. How can I formulate the hypothesis? How can I question? Example, I'm learning more articles. One of them is this: the impact of emergency physician seniority on the clinical efficiency emergency department research, whose patient outcome and disposition. Example, this article said, what is the question for this article? The purpose of this study was to evaluate the association between the duration of the emergency physician experience and this aspect of the clinical performance. I not yet have the researcher question. I'm reading the article, how I say. Example, the other article says the impact of the senior clinical review on patient disposition from the emergency department. In this article, the researcher question is, our study was to assess the influence and effect of real-time senior clinician supervision, because in our emergency department, we have a general practitioner, 7 by shift. We have 7 general practitioner by shift. They reassess the patient and decide if the patient go to ICU, if the patient go for other side. But with our presence, they don't send patient for ICU without consult us. I would like to measure it. How much we are important to be consulted for emergency, for general practitioner to take some decision of a patient, if the patient go to ICU on another side. This is a question I'm thinking about. Example in this article is saying, making an impact on emergency department follow, improving patient processing aside by consulting a triage. In this case example, the question is, our hypothesis was that an ill senior clinician consult for patient replacing the standard triage exposite. In Mozambique, we are using the ETT. The ETT is the inter-agent triage tool. It's a type of triage created by a WHO, a Red Cross, and another organization. This triage prioritizes the red as the emergent patient, the orange as the urgent patient, the green as not urgent patient. We have 4 colors. We are implementing this type of triage, the inter-agent triage tool for Central Hospital. That's why I'm thinking to measure how this instrument, how this tool is important for the emergency. Example in this article, the impact of emergency departmentalization and the patient follows after integrating with a general practitioner cooperative and observers and stats. The question of this article example, the objective of this study was to examine the effect of an emergency tool utilization and the plan dependent follow-up. And finally, we have this article, how Brit was saying, we have more problem with ICU. When we decide to take a patient for ICU with our criteria, I think the criteria to take a patient for ICU would be the same with the ICU. But when they take the patient to the ICU have another criteria. But the patient, when you go for the ward or another side, probably they die and deteriorate. I would like you to measure the impact of emergency department care on intensive care unit. The question is specific: what impact does initial emergency department care of a critical ill patient downstream ICU costs? There are surprisingly few data which we think to address this question, but we examine, I will say, the article. That's why I have many ideas how to measure our impact at Central Hospital in different areas. Our relationship with the ICU, our relation with another room of observation, or in general. That's why I'm reviewing the literature. we're facing a problem. Example, actually, we are only at the adult emergency, but the pediatric room, we are not doing nothing because we are only 3 emergencies at center also. That's why we and Dr. Brian and the pediatric department were creating the opportunity to create a research room there at the pediatric emergency. Sometimes we pass there with our resident and we as a specialist, because now we are doing only shift at the adult service. It's not good because the emergency physician can see adult and the pediatric patient. That's why I would like to start our impact at pediatric, but we not yet are there. We first need to create our research room at pediatric. After that, we measure our impact at the pediatric emergency. This is the idea I have, and I will compartilate with my colleagues to do how can I measure our impact. Because at the Maputo Center also, monthly, have a meeting where each department, emergency department, pediatric department, surgery, orthopedic, present the studies. And we need to start to present our study at the emergency department at the clinical session of the hospital. That's why I'm trying to do any study and research project to present at the hospital. But with the help of Dr. Brand, maybe Dr. Abigail or Kevin, can we finish this? Thank you.
Rito, thank you so much. It really warms my heart, actually. I know how hard, especially our seniors have worked to come to understand and feel confident with the idea of doing research. And this is really exciting to see that you're developing these questions. And I think one thing we have seen in Mozambique is the results of research done in other parts of Africa on the impact of emergency medicine helped us convince the Ministry of Health and the hospital of the importance of implementing emergency care there. And so as we start to do research of our own and measure the impact, we are going to help the colleagues that we know we have in Uganda, and Botswana, other countries where they're still working to build emergency medicine residencies. So I'm so excited to see this, and I really thank you for sharing these big next questions.